Good afternoon. This is Carlo from Phage Corporation. We're joined by Dr. Zalzala from AgelessRx, and we'll be discussing the pilot study utilizing low-dose naltrexone and NED for the treatment of patients with post-COVID-19 syndrome, also known as chronic COVID, also known as the long hauler population. So we'll go through kind of what the disease burden that's currently being presented with for patients, the highlighted unmet needs, and how we're designing a study to be focusing on decentralized access to monitoring treatment outcomes and being managed by AgelessRx. For those who are watching and recording right now, feel free to accept the consent procedure button, and then we can go ahead and get started. Dr. Z, thanks for joining us.
Thank you very much for helping me put this together, Carlo. All right, I'm just going to jump right in it. Thank you everybody for listening today. I hope I can make it worth your time. We're at AgelessRx. We're trying to join the fight in COVID, and there's a big need to help trying to find therapies that's effective against post-COVID, chronic COVID, post-COVID, long COVID. There's a bunch of different names to it, as Carlo mentioned. So this is our contribution to it, and we hope you'll be interested in being involved. Let's see. Next slide. There we go. All right. So what is COVID-19? I mean, for those who doesn't really need an intro, it's been on the news, but basically it's, COVID-19 is the name for the novel coronavirus disease caused by the SARS-CoV-2 virus, and symptoms range anywhere, from no symptoms up to about 30% of people mild to severe, and symptoms can last anywhere from a few days to a few months, or longer. We're not sure how long long COVID is going to go on for some people. There's very few authorized FDA, FDA authorized, nothing FDA approved. There's emergency authorized medications currently, and we're planning on a acute COVID trial coming up shortly, so stay tuned for that. And the purpose of that trial, without getting to details, is we're hoping to kind of not only reduce the symptom severity, but we're hoping to see if we can reduce the incidence of this post-COVID syndrome. What is post-COVID? Again, it goes by many names, but basically, after somebody should have recovered from the acute, they go on to have many symptoms: fatigue, headache, shortness of breath. I was reading an article the other day. 250 different symptoms have been identified for post-COVID. And the incidence is anywhere between 10% to 30% of people who got sick with COVID, and it's much, much higher for people who are hospitalized. I think up to 80% or even approaching 100% for some populations. And currently there's no consistent FDA approved or even FDA authorized medication for the treatment of COVID. It all comes down to symptomatic treatment. And we're hoping to, like I said, kind of find symptoms that help treat the underlying cause. And I'll explain that probably slide number 20 or so. So be patient with me here. And of course, our ultimate goal is we want to make these therapies available. And obviously there are several drug companies out there looking at new molecules, but they're in phase 1, phase 2 clinical trial. Anybody knows about the clinical trial and the FDA approval, it could take months to years and many millions of dollars to get them through the FDA approval process. And even then, they probably won't be readily widely available, and they're probably expensive to begin with. And the interesting thing is there's a lot of overlap between ME and chronic fatigue syndrome, fibromyalgia, and post-COVID. And that's actually why we're hoping we can make a difference, why we're expecting we can make a difference with post-COVID. So who am I? My name is Sajad Zalzala, Dr. Z for short. I'm the medical doctor and co-founder of AgelessRx. I'm one of few physicians licensed in all 50 states. I've done a lot of telemedicine, and I'm trying to bring longevity and longevity therapies to telemedicine, and I have a passion for holistic and functional medicine. Again, trying to get to the underlying cause of disease, in which case, the aging is, premature aging especially, is the mother of all causes of underlying disease. Just a quick blurb about AgelessRx. We're the first of its kind online longevity platform. Basically, our motto is longevity prescriptions delivered to your door. We're a telehealth platform that provides longevity prescriptions. We launched back in October of 2019 with metformin. Shortly thereafter, we added NAD patches. low-dose naltrexone, and these are the two things that we're actually studying. And we've added a few more with several other things on the horizon. And for those of you who listened to my rapamycin presentation a couple weeks ago, we're also getting into just more general longevity clinical trials as well. All right, so let's jump into the study here. So it's a pilot program. I mean, it's not going to be large. We're not talking about huge populations. We just want to see if we're going to make a difference. So it's going to be small. It's going to be quick. It's going to be efficient. So we're hoping to identify 30 and 30 people for control, 30 people in treatment group. People who've had COVID, in the last 1 to 4 months, although we might consider including people a little bit beyond that timeline. And anybody who has a significant fatigue, as indicated on the Chodler fatigue scale. And it's going to be 12 weeks of treatment. We're going to be doing surveys, and I'll get a little bit more detailed on the line. What's our goals here? Our primary endpoint is reduction of the fatigue scale score, and we're also hoping to make quality of life improvement using a standard questionnaire called the SF-36. Beyond the pilot, we want to, if the pilot is successful, and we're hoping it will be, we plan to expand that to include perhaps biomarkers, try to identify different ways to identify and treat COVID, post-COVID, get more insights into, maybe some underlying causes, which might lead to additional therapies and things like that. We're also considering adding things like ketone esters, glutathione, metformin. As suggested, that could help as well. That's part of our acute trial, but it could have some role as well with the chronic, and of course nutraceuticals. And then once we've kind of proven or suggested that these can be beneficial, then patients can come get these therapies. We will make it widely available on our telemedicine platform. Inclusion criteria, you can read it in more detail, but basically, you have to be willing to use the treatment. Like I said, the fatigue score of greater than 9. You have to be, able to do online questionnaires and things like that. Who can't enroll? We try to include as many people as possible, but there are some obvious things, like if you have like significant liver or heart problems, you're probably not appropriate for a remote clinical trial. And of course, if you're currently using LDN or NAD, that would not be ideal either, because then we wouldn't know, whether the study protocol is working or not. And of course, you can't be in another trial. And speaking of remote clinical trial, that seems to be a trend, a shift towards decentralized, away from hospital-based or clinic-based clinical trials, more towards telemedicine-based. There's been a huge push on that. In fact, during the pandemic, almost all non-COVID related trials shut down, and now everybody is trying to scramble to restart a lot of clinical trials and see if they could do it remotely. But from the get-go, we knew we wanted to do a remote trial, and we're going to try to do as much as we can remotely. What is post-COVID? Like I mentioned before, basically it's anything respiratory, musculoskeletal, neuropsychiatric sequelae. It's also been seen and described in other coronaviruses such as SARS and MERS, and there's a lot of parallels with these other coronavirus, post-coronavirus syndromes. Possible causes, we think maybe the virus might be lingering longer in certain tissues, and we think that people who just never made a robust antibody response are more prone to it. It could be, you get rid of the virus and then it's hiding somewhere and then comes back again, bites you again. It could be the virus is completely gone, but now it's kind of set up an inflammatory and immune dysregulation cascade that's causing all sorts of problems. Some people think maybe people are just deconditioned because they've been in bed for a week, sick with COVID. And of course, psychological factors can also be at play. It's for most people, it's probably a mix of them. This is a very busy slide, but you don't necessarily need to memorize it. But basically, I just wanted to show what the BMJ, the British Medical Journal, what they're recommending for their general practitioners to do for long COVID in primary care. what's missing on this, if you kind of look through it, what's missing on it is any mention of any kind of therapy other than symptomatic treatment and ruling out like other diseases. So there's no talk about treating the underlying cause or even attempting to find the underlying cause. It's basically all supportive care, or if there's like a major respiratory or heart condition, send it to a specialist so they can treat, usually with, again, symptomatic care. So that's kind of disappointing from my perspective, because I feel like we should be doing more. And that, again, that's the purpose of our trial. All right, a little about LDN. LDN is one of my favorite medications of all time. It's right up there with metformin, I think. But it basically, it's a non-selective opioid antagonist, high affinity for the mu opioid receptors. It was FDA approved, I believe, back in the 80s or 90s for medication-assisted treatment of opioid and alcohol dependence at the 50 milligram dose. Brand name is Revia for that. But what a lot of people don't realize, it's also FDA approved for weight loss in combination with bupropion called Contrave. A lot of people associate naltrexone with opioids and opioid addiction and addiction clinics, but it's not a controlled substance. A lot of people have that misconception. It's an anti-control substance. It's not addictive. It's not habit forming. It's anti-addicting, anti-habit forming, actually. Anyway, so why they call it low dose is because there's this paradoxical dose effect where this low dose refers to 10 milligrams or less. Some people say 15, depending on how you ask. That's another problem with LDN. It hasn't been studied as rigorously as we'd like it to be. The most common dose is 4.5 milligrams you'll see in literature, but we're not 100% sure if that's the right dose for everybody. That's the dose we're studying, just to be, just to be systemic about it and systematic about it, and also match up with the current existing, and that seems to be the dose that most people respond to. But again, in my experience, it's anywhere between 3 milligrams to 6 milligrams for patients suffering from chronic fatigue, fibromyalgia, and it seems to really help those symptoms. It works by binding to TLR4 as a glial cell inflammatory modulator. It's probably one of the most powerful I've heard from some of the research I've spoken to. Is probably one of the most powerful glial cell inflammation modulator. It also has this effect on the endorphin system. It's the internal opioid system of the body, which has a lot of functions to it. Immune cells, gastrointestinal cells, and of course brain cells. The runner's high, if anybody experienced the runner's high, that's kind of a release of endorphins. And what LDN is thought to do is by doing an immediate release, small dose, low dose, you get this short-term blockage of opioid receptors, which causes almost like a positive feedback loop to upregulate the OGF and the opioid receptors. The history of LDN, back in 1985, Dr. Bahari, he was, looking at various different treatments for AIDS patients. Back then, we barely knew what AIDS was, let alone had any treatment or promise for it. And so a lot of people were trying various different experimental, repurposed things like that. And it just so happened he discovered that, naltrexone, a low dose, helped increase survival quite a bit in AIDS patients. Of course, antiretrovirals came on the scene, and LDN was completely forgotten, for newer and shinier medications. And the interesting thing, though, in AIDS patients, it was observed that they had 20% or 80% reduction, only 20% normal endorphin levels, and LDN at that 10% of the regular dose caused 300% increase in endorphin levels. Sorry, all these percent signs can throw you off a little bit. Fast forward 2007, you had one of the first articles on LDN in Crohn's disease by Penn State. 2009, there was a really good study out of Stanford by Dr. Younger. He did actually 2 pilot studies, and this, we'll talk about that a little bit. And then now, if you go on PubMed, there's 230 articles, case reports, small scale clinical trials, things of that nature, and it's growing. Seems like it's growing every day. I'm in the Detroit area, and there's actually a hospital called Beaumont, and they're currently undergoing the SYNC trial. The N is naltrexone, the K is ketamine, but the first line for people coming into the hospital with acute COVID, they're giving people LDN. And I was actually quite surprised because I didn't realize hospitals were thinking about LDN, but somebody is. It's going to be a few months until their study is published, so it's going to be a while. I personally have treated over 3,000 people with LDN, and results for a lot of people have been great. And like I said, it's one of my favorite medications. Now, why are we choosing it for post-COVID? There seems to be a lot of other things out there. Well, like I mentioned before, there's a lot of overlap between chronic fatigue and fibromyalgia, and LDN just seems to do a really good job with those disease conditions. The Stanford study I was telling you about, there was 2 of them. One is a double-blind, placebo-controlled. You get almost a 30% pain reduction, improved general satisfaction, mood, and then the pilot study showed a 30% reduction in symptoms. And then this is very interesting. We actually ran across this from a company that was bought out by 23andMe called Cure Together. They did a survey of 1,400 people with fibromyalgia, and they asked them how to rank the effectiveness of 104 treatments for fibromyalgia. And you've got things on here. I don't know if you can see this or not. You've got things on here: Cymbalta, Lyrica, Savella, Effexor, all those FDA approved or conventional treatments. If you look here, they actually all score in the negative range, even though they're very popular and very well known and FDA approved for one of the only FDA approved medications. But it's actually quite interesting how patients report that doesn't help. It actually makes things worse for some patients. Gabapentin seems to be kind of neutral according to this. But look what sticks out above all the rest. LDN, we've kind of showed it here for you in red. It's on the left side of the axis because it's not very popular. There's a popularity, from very popular. So apparently rest is the most popular thing. And LDN is above rest and quite a bit above Vicodin. So I just thought I'd point that out because that goes to show that, there's probably something to it here. We've put a link to this article as well. Now let's shift gear to NAD. NAD is Nicotinamide Adenine Dinucleotide. Don't make me say that 3 times fast. But basically, a lot of people have learned NAD, NADP, NADH, NADPH as part of the Krebs cycle back in high school, probably. High school biology, probably. I had to memorize the Krebs cycle. I don't know about you, and then I wanted to quickly forget it. And for the most part, it's actually been forgotten, from a medical and scientific perspective for decades, until more recently it was found to be a lot more important to human health than we thought. We thought ATP was a rock star when in fact, and NAD was just kind of its wimpy little brother, but actually NAD is actually very important. It's involved, found in every cell in the body, involved in several metabolic pathways. It's an energy carrier in the mitochondria. You can't make NAD without, you can't make ATP without NAD. And it's also a cofactor or a fuel of sorts for several different enzymes, very important pathways and enzymes that involve in DNA repair, cell survival, inflammation. And as you get older, you actually get a double whammy of a decrease in efficiency in making NAD and an increase in demand. So, you need more, but you make less because your enzymes and nutrition and things like that just can't keep up. And so it's thought, some studies indicate that by middle age, you've actually dropped your NAD levels in half. And that seems, and if you don't have enough NAD, then these pathways start to fault and fail. And that's kind of where you start getting issues with DNA damage and, accumulation of all sorts of, sludge and things like that in the cell. And so it's thought that by adding more fuel to the tank, in the form of NAD, it can really help revigorate some of these repair pathways. Quick fact here: you couldn't live more than 30 seconds without NAD. But if I gave you, if I were to somehow give you something that freezes the enzymes that make NAD, you wouldn't last more than 30 seconds. So it's critical to human metabolism. Now, how do you boost it? You can't take NAD like in a pill form because you can try to boost it. There are precursors like nicotinamide riboside, NMN, and niacin or B3. Some people get good results trying to boost it that way. You do have to take rather high doses in order to get your levels up. And some people just have problems converting. Again, your machinery as you get older just not as robust as it used to be. There's been a proliferation of IV clinics that offer NAD, and it seems like a lot of people are flocking to them. They're getting all sorts of benefits with the IV, but you have to sit in that chair for 4 to 6 hours, and it could be very costly. Direct injection that's available. Some people do that for home injection, and then iontophoresis is what we've elected to do for this study. We feel it's the easiest and one of the most effective ways to get NAD directly into the body. We use a patch called the iontopatch Stat. It's FDA approved. Medical device. It is listed as a medical device. It's actually FDA approved for pretty much any charged molecule. It's used extensively in sports medicine for like tendonitis and things like that, where they put like dexamethasone and other types of steroids on the patch. But in this case, we're kind of repurposing these patches for another charged molecule, NAD. Interesting enough, you can also use glutathione, and we have some patients in our clinic who put NAD on the positive and glutathione on the negative, and they get a double infusion. We're still investigating to see how effective that is, though, so don't run out to get those double patches just yet. It's a 4-hour wear time, and we think once a week is enough to boost the NAD levels effectively. So why NAD for post-COVID? There's been a couple articles on it. A hypotheses article hypothesized that NAD deficiency may predispose to the aged, obese, and type 2 diabetics to mortality through its effect on SIRT1 activity, and that subclinical nutritional deficiencies may be unmasked during these times of oxidative stress. So the virus stresses your body up. You're kind of like on the edge, and then the virus comes and throws you over the edge, and kind of uncovers the deficiencies. And then, again, this dysregulation, the NAD metabolome, it's thought that NAD puts pressure, the virus puts pressure on NAD and its precursors, and it just kind of seems to deplete it a lot more quickly. And this article here concluded that interventions to enhance NAD level may boost innate immunity to coronavirus. Here is a busy diagram that I borrowed from Nikita Alexandrov. If you're listening to this, thank you very much for putting this diagram together. I actually modified it slightly to include the stuff here in blue, because he didn't have any LDN on his site, on his chart, so I decided to add it. But basically, what this shows is the various different pathways that it's thought that contributes to this long haul COVID. And how NAD and like I said, in my case, the LDN addition can help fight that. So if you look here, you've got tryptophan, which is an amino acid. It's thought that the virus, can deplete deplete tryptophan, which depletes serotonin, and then that kind of depletes the precursors to NAD, and you end up with a depleted NAD. In addition to that, you have more demand for NAD. And so you kind of get a double whammy there, very similar to what you get to, when you get older. He's recommending nicotinic acid, which we talked about. But again, I feel that directly boosting NAD, cutting out the middleman, so to speak, and just go right for the jugular, so to speak, and boosting NAD would probably be more effective. For LDN, it's very interesting that in this chart, there's a lot of talk about cytokines, immunosuppression, and things of that nature, T cell activity, and this is where LDN is thought to work as well, if you remember my discussion earlier. And so you can see that this combination therapy has a lot of promise because it actually works on 2 separate pathways to help with long COVID, or at least we hope that it'll help with long COVID. All right, so you've got long COVID. You want to get help. You want to get enrolled in the treatment. So what do? We have a landing page on our website, AgelessRx post-COVID. There's a at the bottom there's a link there to get to fill out a screening form to see if you qualify. And then once you qualify, somebody from our research team will contact you and get you on your way. And the process is basically consenting and enrollment, and then we'll do a baseline evaluation, including a medical history intake, that fatigue score I was telling you about. SF36 is a baseline, and then you'll talk to one of the clinical investigators, such as myself, and then that's when the study medications or placebo ship out. The dosing schedule. So LDN, like I said, the standardized dose is 4.5 milligrams. We feel that's the best dose to study here. We're going to start we're going to ship out patients LDN tablet or placebo, and we're going to instruct them to start with a quarter tablet. Some people have some side effects when they first start LDN, and so we're hoping to minimize the side effects by starting with a low dose of LDN, and then we're going to move up as tolerated. If there's any problems during that time, our clinical coordinators will be around to answer questions and help kind of provide guidance on ramping up to the full 4.5 milligram dose. We don't anticipate too many problems. It's rare for a patient not to be able to get up to that 4.5. In perspective, the 50 milligram dose is usually just prescribed. If somebody were to walk into addiction clinic, they're just written the 50 milligram dose. There's no ramping up or anything, but something about LDN, some people have a little sensitivity to it. For the NAD patch, it's standard. Where you apply one patch. Actually, I got one on right now. You apply one patch once a week, and we'll be providing instructions on that. At weeks 2, 4, 8, and 12, we'll be asking about side effects, and kind of repeating the toddlers and the SF36. And just a quick word about placebo. Nobody likes to be in placebo group. It's a bummer if you find out you're in the placebo, but it's really important. The placebo effect can be very powerful, especially when it comes to subjective measures, and that's what we're measuring here. So it's critical that we have a placebo group and that we have volunteers, who are willing to participate in the trial with the knowledge that there's a 50% chance they'll be in the placebo group. However, I feel, that I owe those placebo participants something, and we've decided to grant them, if the study is successful, everybody in the placebo group will get 12 weeks of the study medication free of charge. Now we also get the questions, I'm already on LDN or taking NAD or precursors, can I still get involved? Yes, you can. And that includes really anything that you've tried, or that you're trying or have tried to help with your battle against post-COVID or long COVID. We feel that it's very valuable to collect this information and place it in a repository where we can analyze it. And I think it'll help us gain valuable insights. Perhaps guide therapies that we haven't thought of, or therapies that might be out there. For people who are on LDN, for example, maybe 4.5 milligrams isn't the optimal dose, and then we can kind of go back and look at optimal dose. So there's a lot of reasons why it's important for people to participate with us. And other people. There are plenty of other people, organizations out there, and we're reaching out to them as well. If you're involved in any of those organizations, or if you have some sort of registry yourself, please email us, research@AgelessRx.com. We'd love to hear from you. We'd love to kind of coordinate and see what we can do to kind of put all the data sets together. The more data we have, data is power. The more data we have, the more power we can have to fight the effects of COVID. All right, that concludes my presentation today. Sorry for speaking so quickly, and it's being recorded, so you can always go back and slow it down. And the slides will be available as well. If you have any questions, again, research@AgelessRx. You can check out our other research initiatives by going AgelessRx.com/research, and I'll be open and available for any questions.
Dr. Z, thank you so much for going through the slide deck and being available beyond that to actually help support and access treatment to help elucidate a better understanding of chronic COVID and how to actually make those impacts. To the engagement we've been having with some potential participants that are getting screened right now, there were some questions that came in that I'd like to go through with you. But if anyone on the call has any questions, feel free to type it on the chat or just unmute yourself as we continue. The first one is, Dr. Z, how long does chronic COVID last that we're able to observe? And if these treatments are utilized, how long will they need to be on treatment to have a lasting effect?
So to answer the first question, we really don't know. it's still something that's being investigated in terms of how long it'll expect it to last. Based on other post-viral illnesses, like I said, kind of from the previous SARS and MERS, it can last anywhere from a few weeks to years or more. I think there are people out there who are still suffering from kind of the post-SARS, post-MERS. Like I mentioned before, there's a lot of overlap with chronic fatigue syndrome. And for some patients, unfortunately, I wouldn't say a lot, but for some patients, it seems like once they get into this vicious cycle of inflammation and immune dysregulation, it's really hard to break that cycle. And so I think, until and unless they break that cycle of inflammation and dysregulation, immune dysregulation, this seems like the symptoms just keep going on and on. In terms of the second question, I think that's going to vary person to person. Like I mentioned, that little diagram with the NAD battery being, depleted. I think it all depends on what your status was before COVID. How well you're able to absorb nutrients, other stressors in your life. I think it's really going to vary person to person. We're hoping 12 weeks is going to be enough to make a major difference. We could see sooner. We could have some patients who require further treatment. We won't really know until we start the study and go from there.
For the COVID-19 long haulers, there was a question that came up around the vaccine, if it would offer any potential benefit to help with the symptom management of long COVID. Aspects around reinfection. Would long COVID potentially get worse, which I imagine likely would be. But what are your thoughts on folks with chronic COVID getting access to vaccines in your mind?
That's a very tricky question. I mean, on one hand, you've got, it's like I mentioned before, it's thought that some, most, all, we're not sure, of post-COVID sufferers just didn't form a robust immune response to begin with. Whether or not going back, after the fact, months after the fact, or weeks after the fact, and giving them a boost of, an immune booster, vaccine booster, will help, drive. I really don't know. I would suspect that we may not necessarily see much benefit with a vaccine, just because I feel that the damage has already been done. COVID has come through. The body didn't make an immune response to clear it fast enough, and so I don't think having antibodies, like a robust antibody after the fact, is going to do much. That's just my opinion. I'm not an epidemiologist. I'm not an immunologist, but that's just my opinion. I don't want to discourage anybody from taking the vaccine, but that's just my assessment of the situation. Like I said, I think the issue is an inflammation and dysregulation, and I don't think vaccine is going to do anything for that.
Thank you. Marcia in the chat produced a question that goes along with the next one I had prepared, but for Marcia's first, what are some of the side effects of low-dose naltrexone versus some of the other medications of fibromyalgia? I guess getting to that lower threshold cutoff that some of those more popular brands didn't kind of make it over.
So low-dose naltrexone, the most common by far reported is sleep disturbance, and it could be anything from vivid dreams to just a little bit of restless sleep, all the way to like flat-out insomnia. Flat-out insomnia is pretty rare, but it is it is reported. That's the most common, and usually you can mitigate that by starting at a lower dose. Still, that's why we start people at the quarter tablet. When I prescribe it clinically, I start people at 1.5 typically, or lower. Sometimes I go all the way down to 0.5. And then starting up slowly, and usually the insomnia or the sleep disturbance side effects subsides over time, over the course of a week or two. And sometimes it comes back when comes back for a short time when you increase the dose again. Other side effects, I mean, it seems like every day somebody's reporting a side effect, but they're pretty rare, and they're not serious. A lot of times they're mostly annoying. Some people report an increase in fatigue, headache, nausea, dizziness. I suspect there might be some kind of immune reaction going on, maybe perhaps like some kind of a detoxification or immune reset. I've never really been able to figure out exactly why. And of course, there's always going to be about maybe 15 to 20% of people in my experience who either can't tolerate LDN for whatever reason. I've had several patients like that, or they just don't respond to LDN. I think you know, there might be other things going on where LDN is just not enough, or just not, won't do the trick. To answer the second part of that question, I mean, the most commonly prescribed medications for fibromyalgia is Cymbalta and Lyrica. I mean, I don't want to talk bad about FDA approved medication, but people who've been on those, sometimes they work really well. Don't get me wrong. I've had patients, you know, I've used them in my clinic before on patients, and some patients come back and they love them. And other times, to be honest, they cause a lot more side effects than they're worth. Even if you look at the clinical trials, you know, they were, you know, for, you know, people in the fibromyalgia societies and, you know, patient groups and things like that, you know, back when these medications were being studied, they seemed to be pretty disappointed with the results, because it seemed like roughly only about 30% of people will get a response, and only by about 30%. So you got 30% of people getting a 30% you know, improvement in their symptoms. So that means 70% of people will either get no improvement, or like that one Cure Together, I believe it was, that I showed you, will actually cause a worsening of symptoms.
And I also know that there's other neurological components, like a quality of life, will often cause double vision, irritability, manic depressive episodes, mania. So it's adding more onto the pain that already exists. So just to kind of add those things from my own perspective. To the question that I had beforehand, oh, Dr. Z, did you want to say something?
No, I was gonna say, yeah, I mean, absolutely. Again, I mean, the more stressors you pile on, I think the harder it is to recover, because that just means there's more and more demand.
Getting to the fibromyalgia, you had touched on how the previous research for low-dose naltrexone had shown some promise in that aspect, and it touched on the overlap of the chronic fatigue syndrome and the myalgic encephalomyelitis. But has this combinational therapy of NAD and low-dose naltrexone been used in those two other indications that you know about?
Not officially, not in any clinical trial that I know of. We've had several patients through the AgelessRx clinic use that combination on their own, and we've gotten, you know, good feedback from that combination. I think the reason why it hasn't been studied in combination is, well, first of all, I mean, if you look at vast majority of clinical trials, they're usually single therapy, you know, trials, and so just combinations just never really do well, especially, you know, when you're talking about more than one therapy at a time. And the other reason, NAD, like I said, NAD was forgotten for a long time, and just in the last few years has gotten the respect it deserves. So I don't think anybody's really, you know, even considered doing a combination trial. But, you know, given how well LDN helps with fibromyalgia and with chronic fatigue syndrome, you know, I'm very optimistic that we'll see results. But I wanted to add NAD just to make it all the more potent, and get as big a bang as we could from the study. And then we can go back and kind of tease out which one is stronger, which one's better, you know, things of that nature. But like I mentioned before, there's a small pilot. We just want to see if we can make a difference, and then expand.
I'd like to add as well as whenever you have that clever mechanism display, if you can pull it up on the screen, that you're really coming at this novel epidemiology of chronic COVID, where you're able to impact potentially the immune component as well as the metabolic component at the same time. So it's, you know, we have a very large umbrella of patients in a very untenuous category. So being able to move any of those needles would be able to have an outcome that I think when we have a better down the road outcome of stratifying what is a long hauler, what is a subtype of a long hauler, we might do a better job of personalizing those access. But those were just kind of my thoughts on why combinational is so useful when we're discovering more and more about a disease going forward.
Exactly. Good, very good point.
And thanks for migrating to the slide that I was sure that was somewhere within arm's reach. So this research, I mean, there's so many routes we're going to go into, but do we have any ideas of where we're going to look to try to publish this? I mean, we're doing a study. Is there any goals of where this should be distributed into? How do we want to try to impact clinical decision making for long haulers?
I have not thought about which journal. That's something that you know, that I'm going to be leaving to the research team to help us figure out where to publish it. I mean, to be honest, we're just looking to see what the data shows. I have a strong suspicion that this combination will work. Like I said, just based on you know, anecdotal evidence from patient reports and things like that. But we're not sure to what scale. You know, how much of it could be placebo. And so, so my primary goal is just to see what I can do, what we can do to help with patients recover from this. In terms of like being in journals and, you know, things like that, that's kind of a secondary, you know, secondary goal. Um, you know, I'm hoping that this will be, you know, my quite honestly, I'm hoping this will be picked up by you know, perhaps mainstream media outlets and things like that. Perhaps we can then start talking to, you know, universities and other organizations to start expanding it. I mean, this is a small trial. It's just the beginning, we're hoping. But the ultimate goal is to kind of expand it and make it larger and you know, try to no long hauler left behind type of thing.
No, I think being able to broaden the attention to this research is very useful, especially for this next question about access to
Mm.
treatment after a trial. You did touch on the placebo arm would, you know, have access to 12 months that AgelessRx would provide and help monitor for that safety. But what happens if this does go well? Can a patient go and get this prescription from their general provider? Or what do they do once there is success that's been able to be validated on a study like this?
Yeah, so I mean, LDN, like that slide showed, you know, very effective, but not very popular. Not very many doctors know about it. And you know, one of our goals as an organization is to not only metformin, you know, rapamycin, LDN, other therapies, is to make them more widely available. If not through us, you know, then you know, any doctor should be able to prescribe these. The issue is, you know, a lot of doctors may not be necessarily knowledgeable, or like I mentioned before, naltrexone has kind of a guilt by association problem. And to answer your question, I mean, you know, patients are more than welcome. We currently offer it, both of these therapies on our online platform. But we're also hoping that, you know, we can gain the trust of prescribing providers out there, physicians, nurse practitioners, things like that, to start prescribing these on a wider basis if it works out. I mean, we're not looking to patent anything here. You know, we're not looking to, you know, to monopolize it. You know, obviously we'd love if people come use our platform. That's what it's there for. But, you know, we would have no problem sharing the data with people, you know, maybe providing the study data to people to take to their doctor to discuss it. So ultimately, I mean, that would be the ultimate goal for anything that we do, COVID or not COVID, is to raise awareness and accelerate the field. And I think anything a patient can do to raise awareness with their physician or with their community goes a long way for that.
And then not so much wearing the researcher hat, but coming at it from a provider. If somebody's not able to engage in a trial like this, what should they be trying to think about care coordination with their provider team? What specialists should they be trying to rope into these discussions to help manage the current evolving landscape of chronic COVID?
That's a very difficult question to answer because it, there's not really much, like I mentioned in that BMJ article here. I mean, there's not very much discussion about, you know, trying to find or treat the underlying cause. That's a field of medicine called functional medicine, and it's catching on in mainstream, but it's not really there yet. I mean, you have some universities and organizations that have cropped up around functional medicine, but it's still not mainstream yet. And of course, you know, there are a lot of functional medicine providers out there. Some are great, some are, some may not necessarily be so great. So I can't recommend them all as a, as an entire group. But in general, I mean, the mindset of a functional medicine practitioner is to try to dig for and treat the underlying cause. There are, like I said, there are a lot of organizations out there where you can find a functional medicine provider.
I think it's always great to raise those points because, this is a really easily accessible clinical trial based on the enrollments, inclusion, exclusion. There's so many points where people probably don't have the ability to commit or be able to adhere to a trials protocol. So it's always great, I think, to just kind of end with what else people can do. And it's really learning how to advocate for yourselves as we learn more about this disease indication in the next coming months, if not the next year.
Yeah, like I mentioned, I mean, if you are doing something on your own, Nikita Alexandrov, he recommends, vitamin C, selenium, as part of this pathway as well. And if you're doing that, I don't see a problem with that. More power to you. But I think there's a lot of things that patients can do. And it may not work for everybody. I mean, to your point earlier, we don't know. There may be a lot of overlapping aspects, but I think everybody's a little bit different. Again, going back to the LDN not working for everybody, not everybody goes through the same pathogenesis to get from well to sick. But if you do find yourself, trying various different modalities, things like that, please, contact us so we can include you in the registry to perhaps take what you're doing and look at it from a more scientifically rigorous perspective.
Thank you. Those were the questions that I had prepared prior to the call that came in from interest either through the clinicaltrials.gov registration online or that came in through the research at AgelessRx inbox. But thank you so much for taking the time to produce this presentation, pioneer into repurposement studies to impact patient outcomes. Are there any final words I want to add for the listeners and or future audiences?
Well, we'll be doing more of these clinical trials, whether it's COVID or general longevity or perhaps other conditions related to premature aging. So stay tuned. If you have if maybe if you've recovered from long COVID, or you've never got COVID, so feel free to email research@AgelessRx and let us know that you're interested in the field. We've always got something cooking, and so we'd love to have you participate with us.
Perfect. Well, everyone, thanks for joining us.